Hi, everyone, and welcome to the Scleroderma Research Foundation's second annual Patient Forum, Collaborating for a Cure. My name is Susan Feniger, and I'm a board member here at the SRF. I'm here today because scleroderma has impacted my life just like it's impacted many of yours. Sharon Monsky, who lived with scleroderma, was one of my dearest friends. So when she founded this organization, of course, I joined to help advance the search for a cure. In my time here, I've seen amazing progress, and I am really thrilled to see how our community of researchers and advisors continue to push the needle forward. It's so exciting to see all of you here because research is the key to ending scleroderma, and your collaboration is the key to moving research forward. Research is at the center of all we do at the Scleroderma Research Foundation, and your partnership is so very important to making progress. Together, we can end scleroderma. Thank you so much and have a great day.
Susan, thank you so much and welcome everyone. I'm Luke Evnin, chairman of the Scleroderma Research Foundation, and I'm also a patient. I've had the honor of leading the board of the SRF for over 20 years. And today, I'm honored that you chose to join us for our second annual Patient Forum, Collaborating for a Cure. And I'd like to extend my thanks to the scleroderma experts partnering with us to share research updates and information on symptom management and how you can participate in research. First, let me share a little bit about the Scleroderma Research Foundation, an organization close to my heart. The SRF is a powerful, vibrant, and enduring pillar of the scleroderma research community. We recruit expert scientists and clinicians to serve on our Distinguished Scientific Advisory Board, and we fund innovative investigators whose programs span from basic research to clinical research. We're also the creator and sponsor of the nation's only multi-center longitudinal registry of scleroderma patients. And there, we partner with 17 expert scleroderma centers. In summary, we're searching for answers from cells to patients and all in search of the ultimate, a cure. I'm extremely excited to share that at the Scleroderma Research Foundation, we've taken unprecedented steps to accelerate getting new treatments into the hands of scleroderma patients. To that end, the SRF has recently completed the design and now launch of Conquest, the first ever perpetual clinical trial platform. Conquest is a multi-center international platform trial which aims to speed the clinical development of novel medicines to treat scleroderma, and in particular, the ILD, that is the interstitial lung disease manifestation of the disease. The platform has garnered strong support from the Scleroderma Clinical Trials Consortium, and this platform could have reverberations across not only the scleroderma community, but the entire rare disease community. We'll cover more about clinical trials and this innovative effort in two of our sessions later today. Conquest is an effort inspired by the heart of our mission. We are singularly focused on advancing research towards a cure, but it's only possible through your partnership and your generosity. We can't find a cure without you. The collective energy, inspiration, and of course, the generosity of our scleroderma community is what makes it all happen. So thank you for partnering with us. Together, we will end scleroderma.
Hi, everyone. My name is David Knoller, and I'm a board member here at the Scleroderma Research Foundation. I joined the board of directors in 2015 because I live with scleroderma, and I want to see this disease cured. I'm thrilled to see so many of you joining us, and it's an honor that you've chosen to spend your time with us. Today, you'll hear from some of the most distinguished leaders from the scleroderma medical and scientific community. They'll share with you their latest research updates and some of the ways in which you can help drive discoveries as a patient. Before we begin, I have a few housekeeping details. Today, we'll share 7 educational sessions. The sessions run back to back and start automatically, so you don't need to leave one just to join another. You can submit questions for the Q&A at any time by typing it into the panel on the left side of the screen. We'll select a few questions to be answered live, and any other questions will be answered via direct message or a follow-up email. Lastly, we have a number of interactive activities that you can complete for the chance to win some great prizes. You can go to the Forum Games page to learn more at any time during the day. All right. Now, it's my pleasure to introduce the first session, Scleroderma 101, What You Need to Know, hosted by Dr. Elana Bernstein. Elana J. Bernstein, MD, MSc, is Assistant Professor of Medicine in the Division of Rheumatology at Columbia University and Director of the Columbia University Scleroderma Program. Dr. Bernstein graduated summa cum laude from Amherst College and was inducted into the Alpha Omega Alpha Medical Honor Society while a medical student at Mount Sinai School of Medicine. She completed her medicine residency at the Massachusetts General Hospital and her rheumatology fellowship at Hospital for Special Surgery. Dr. Bernstein's research focuses on lung disease and systemic sclerosis, post-lung transplant outcomes of adults with systemic autoimmune rheumatic diseases, and the relationship between autoimmunity and interstitial lung disease. Dr. Bernstein is a part of the SRF-funded CONQUER registry, where she and collaborators are currently conducting a large-scale study to develop prediction models for responses to immunosuppression in scleroderma-associated ILD. So, without further ado, please welcome Dr. Elana Bernstein.
So thank you, David, for that kind introduction, and thank you to the SRF for the invitation to speak with you today. My name is Elana Bernstein, and I am delighted to present Scleroderma 101 during today's Scleroderma Research Foundation Patient Forum. So the goals of today's presentation are to discuss basic information about scleroderma for recently diagnosed patients and for their families and friends, to provide a list of questions patients can ask their rheumatologist about their scleroderma, which will hopefully help patients feel empowered to speak with their rheumatologist about their scleroderma. So the word scleroderma originates from the Greek word sclero, which means hard, and the Latin word derma, which means skin. So scleroderma literally means hard skin. Scleroderma is an autoimmune disease that can affect multiple organ systems: the skin, the blood vessels, the lungs, the heart, the kidneys, the gastrointestinal tract, and the musculoskeletal system. Autoimmune diseases are diseases in which the immune system, instead of attacking viruses or bacteria, attacks itself, attacks its own body. And we don't really know why some people get scleroderma and other people don't. We think there's a genetic predisposition followed by some trigger, whether that trigger is cancer, an infection, or some other environmental factor. Now, there are 2 main types of scleroderma: localized and systemic. So localized includes morphia, linear scleroderma, and en-coup de Sabra. And we're not going to be discussing localized scleroderma today. Today, we're going to focus on systemic sclerosis. So there are 3 main subtypes of systemic sclerosis, and systemic sclerosis is abbreviated SSC. So you'll see this throughout my talk, and I'm going to use the terms systemic sclerosis, scleroderma, and SSC essentially interchangeably throughout today's talk. So the 3 main subtypes are limited cutaneous systemic sclerosis, diffuse cutaneous systemic sclerosis, and systemic sclerosis sine scleroderma. Limited cutaneous systemic sclerosis is limited to skin thickening below the elbows and below the knees. By definition, if someone has skin thickening that involves the upper arms, the thighs, the chest, and or the abdomen, that person has diffuse cutaneous systemic sclerosis. And patients who have systemic sclerosis without any skin thickening are classified as systemic sclerosis sine scleroderma. And here's a cartoon illustrating the main differences between the limited and diffuse cutaneous subtypes. So here, the white area represents unaffected or normal skin, and these grayish bluish areas represent areas of potential skin thickening. So this person here has limited cutaneous systemic sclerosis, and you can see that the skin thickening is limited to below the elbows and below the knees. The face can be involved actually in either diffuse or limited, so that doesn't help distinguish. But you can see here in this person with diffuse cutaneous systemic sclerosis, this person can have thickening of the skin of the upper arm, the chest, the abdomen, and or the thighs, in addition, of course, to the skin below the elbows and below the knees. So the only distinction between limited and diffuse cutaneous systemic sclerosis is where the skin is thickened. So the first question you should ask your rheumatologist is, what subtype of systemic sclerosis do I have? And I'll recap these questions at the end, so don't feel like you need to write these down. Now, we measure the degree of skin thickening using something called the Modified Rodnan Skin Score, or MRSS. The Modified Rodnan Skin Score divides the body into 17 different areas: the fingers, the hands, the forearms, and the upper arms on both sides, left and right, the feet, the lower legs, and the thighs, again on both sides, left and right, and the face, the chest, and the abdomen. And each area is scored from a range of 0 to 3, where 0 indicates uninvolved, normal skin, and 3 indicates severely thickened skin. So the maximum total potential score, Modified Rodnan Skin Score, is 51, and that would only happen if each of the 17 different body areas was scored as a 3, because 17 times 3 is 51. Now, it's actually been shown that the extent of skin thickening, or I should say the extent of dermal thickening on skin biopsy, actually correlates with the Modified Rodnan Skin Score. And here the arrows indicate the thickness of the dermis, and the pink areas are collagen, because patients with scleroderma have excess collagen deposition in their skin. So you can see that this area was scored as a 1, and there's mild thickening of the dermis. This area was scored a 2, and there's moderate thickening of the dermis. And this area was scored as a 3, and the dermis is severely thickened. Importantly, though, skin biopsies are not required in order to make a diagnosis of systemic sclerosis. So the second question to ask your rheumatologist is, what is my Modified Rodnan Skin Score? There are several different scleroderma associated or scleroderma specific autoantibodies that have particular clinical associations. And there are 3 main scleroderma specific autoantibodies. So these are the anti-centromere antibody, the anti-SCL70 antibody, and the anti-RNA polymerase III antibody. So the centromere antibody is seen in approximately 30% of patients with systemic sclerosis and is associated with the limited cutaneous subtype, digital ischemia or digital ulcers, pulmonary hypertension, and calcinosis. The SCL70 antibody is seen in approximately 20% of patients with systemic sclerosis, and this antibody is associated with the diffuse cutaneous subtype and with interstitial lung disease. And the RNA polymerase III antibody is seen in approximately 10% of patients with systemic sclerosis. This antibody is associated with the diffuse cutaneous subtype, rapidly progressive skin thickening, scleroderma renal crisis, so-called watermelon stomach or GAVE, and cancer. Now, there are also some less common scleroderma-associated antibodies. Now, typically, I will check the centromere SCL70 and RNA polymerase III antibodies first, and then if those are all negative, I'll check for these less common scleroderma-associated antibodies, including PMSCL, THTO, fibrillary, U11, U12, U1RNP, and CU. So the third question to ask your rheumatologist is, what scleroderma autoantibody or autoantibodies do I have? Now, usually these autoantibodies are mutually exclusive. So if you have a centromere, you're probably not going to have an SCL70 or an RNA polymerase 3, but rarely someone can have more than one. So there are many potential clinical manifestations of systemic sclerosis, but these are the ones I'm going to focus on today. Raynaud's phenomenon, gastroesophageal reflux disease, renal crisis, pulmonary hypertension, and interstitial lung disease. So let's start with Raynaud's. Raynaud's phenomenon affects almost all patients with systemic sclerosis and is characterized by a triphasic color change upon exposure to cold, whereby digits turn from white to blue to red. So here you can see these very clearly demarcated areas of white color change, and the white discoloration happens because of vasospasm of the blood vessels that supply these digits. Here you can see areas of duskiness. So this blue appearance happens due to ischemia and desaturation of the hemoglobin. And then finally, you see these areas of bright red color changes. And this bright red color change happens due to hyperemia as the digits rewarm. So how do we treat Raynaud's? Well, lifestyle measures are important. So things like avoiding cold when possible. This is, of course, hard to do during winter months in some parts of the country, especially here in New York. But also, things like walking into an air-conditioned room can trigger Raynaud's, or going to the freezer aisle of the supermarket can trigger it. So making sure to wear layers and having gloves or mittens easily accessible, those are both really important. Stress reduction is important because stress is also a trigger, but this is, of course, easier said than done for many. And then smoking cessation is critical. Obviously, smoking is terrible for your health, but it's also really bad for Raynaud's. So people with scleroderma and Raynaud should absolutely not smoke. It's important to avoid vasoconstricting medications when possible. So these include over-the-counter nasal decongestants, stimulants, and the triptans, which are used as a treatment for migraines. The cornerstone of treatment of medical therapy for Raynaud's are vasodilators. So first-line therapy are the dihydropyridine calcium channel blockers. So these might sound familiar to some of you, medication like amlodipine or extended-release nifedipine. If these are not sufficient, sometimes we'll add a phosphodiesterase 5 inhibitor, something like sildenafil or tadalafil. And then, in really refractory cases, we might add a third vasodilator, such as an endothelin receptor antagonist like bosentan, ambrisentan, or macitentan. Sometimes we add an antiplatelet agent, such as aspirin, as adjunctive therapy for Raynaud's. This is more likely to be the case if someone has digital ulcerations in addition to Raynaud's. And this, again, would be a baby dose of aspirin, 81 milligrams daily. And then we sometimes use an SSRI, or a selective serotonin reuptake inhibitor, such as fluoxetine, as adjunctive therapy for Raynaud's. So the fourth question to ask your rheumatologist is, what do you recommend I do for my Raynaud's? Let's move on to gastroesophageal reflux disease, or GERD. Now, the vast majority of patients with systemic sclerosis have GERD, which essentially is a backward flow of stomach acid into the esophagus that can cause a painful burning sensation in the chest, so-called heartburn. In patients with systemic sclerosis, GERD often requires treatment to prevent long-term damage to the esophagus. Lifestyle and dietary modifications are important, such as sleeping with the head of the bed elevated, avoiding dietary triggers, and not eating before bed. But first-line medical management for GERD in patients with systemic sclerosis consists of proton pump inhibitors, which are medications such as omeprazole, lansoprazole, pantoprazole, or esomeprazole. So the medications that end in PRAZOLE are the proton pump inhibitors. Let's move on to renal crisis. Renal crisis refers to new onset or worsening high blood pressure with a concomitant decrease in kidney function. It affects approximately 10% of scleroderma patients and is much more commonly seen in those with the diffuse cutaneous subtype than in those with the limited cutaneous subtype. It's most likely to occur within the first 3 to 5 years of disease, and patients with the RNA polymerase III antibody are at greatest risk. Some retrospective data suggest that renal crisis may be triggered by the use of prednisone or other corticosteroids. Now, a kidney biopsy is not required to make a diagnosis of renal crisis, but here's what you would see if a kidney biopsy were to be performed in a patient with renal crisis. You can see that the renal artery becomes thickened, and there's essentially this onion skin appearance of the artery, which basically obliterates the lumen of the vasculature. And on immunofluorescence, we see a fair bit of fibrin deposition. We treat renal crisis with angiotensin-converting enzyme inhibitors, or ACE inhibitors. So these are medications such as lisinopril, captopril, or enalapril. There are others as well, but the medications that end in PRIL are the ACE inhibitors. And it is critical that as soon as renal crisis is diagnosed, that an ACE inhibitor be started, or even before it's diagnosed. If there's high suspicion for renal crisis, a patient should be started on an ACE inhibitor immediately. So can we prevent renal crisis? And if so, how? Well, there are no data to suggest that ACE inhibitors prevent renal crisis. We do recommend minimizing the use of corticosteroids such as prednisone, ideally keeping the dose of prednisone to less than 15 milligrams per day, if any prednisone is required at all. And I also have patients monitor their blood pressure at home, ideally on a daily basis, and I give them guidelines to call me if their blood pressure is greater than a certain level, depending on their baseline blood pressure. So for example, if I have a patient whose blood pressure is typically 120s over 80s, I want her to call me if her blood pressure is ever 140 over 90 or higher. So that's if the top number, the systolic number, is 140 or greater, or if the bottom number, the diastolic blood pressure, is 90 or greater. But if I have a patient, usually a young woman, who typically runs 90s over 60s, I want to know if her blood pressure is ever 120 over 80 or higher, because that would make me concerned about the possibility of renal crisis. So the next question to ask your rheumatologist is, what blood pressure would be concerning for me based on my baseline blood pressure? Let's move on to pulmonary hypertension. Pulmonary hypertension refers to high pressures in the blood vessels that connect the heart to the lungs. And all scleroderma patients need to be screened for this. And the screening tests include echocardiogram and pulmonary function tests. So an echocardiogram is an ultrasound of the heart, like you see here in this cartoon. It's non-invasive, and it essentially estimates the pulmonary artery systolic pressure, abbreviated PASP, or the right ventricular systolic pressure, abbreviated RVSP. Now, a PASP or RVSP greater than 35 millimeters of mercury is considered to be elevated at most echo labs. And it's important that patients with systemic sclerosis have an echocardiogram at least once a year for screening for pulmonary hypertension, and more often if clinically indicated. Pulmonary function tests are a non-invasive measure of lung function. And the two parameters that we look at when screening for pulmonary hypertension are the forced vital capacity, or FVC, and the diffusion capacity for carbon monoxide, or DLCO. So the FVC is the amount of air exhaled forcefully and quickly after maximal inhalation. And the DLCO is a measure of the ability of the lungs to transfer gas into the blood. In patients with pulmonary hypertension, the DLCO is reduced out of proportion to the FVC. So an FVC to DLCO ratio greater than 1.6 is concerning for pulmonary hypertension. Also, a declining DLCO on serial PFTs over time is concerning for pulmonary hypertension as well. If there is any suspicion for pulmonary hypertension, a right heart catheterization should be performed. So this is the gold standard diagnostic test for pulmonary hypertension. So during a right heart catheterization, a catheter, which is shown here in yellow, is inserted into a vein. So it's usually inserted into the neck, into the internal jugular vein. The catheter is threaded to the superior vena cava, into the right atrium of the heart, through the tricuspid valve, into the right ventricle, through the pulmonic valve, and finally into the pulmonary artery, where a balloon is expanded and the pulmonary artery pressures can be measured. A mean pulmonary artery pressure greater than 20 millimeters of mercury on right heart catheterization is diagnostic of pulmonary hypertension. Now, there are several treatments for pulmonary arterial hypertension, which is one of the subtypes of pulmonary hypertension for which patients with systemic sclerosis are at risk. And so these medications, or I should say classes of medications, include the phosphodiesterase 5 inhibitors, the endothelin receptor antagonists, which I showed you before as potential treatments for Raynaud's. They also include the soluble guanylate cyclase stimulant called riociguat, the prostacyclin receptor agonist called selexipag, and both parenteral and inhaled prostanoids. So the next question to ask your rheumatologist is my echocardiogram or pulmonary function testing concerning for pulmonary hypertension? So the last topic I will cover during today's Scleroderma 101 session is interstitial lung disease, or ILD. ILD refers to inflammation and or scarring of the lungs. And all scleroderma patients also need to be screened for ILD. And screening for ILD in scleroderma consists of pulmonary function tests and a chest CT scan. So again, here's this cartoon of pulmonary function tests. In addition to looking at the FVC and the DLCO, we also look at something called the total lung capacity, or TLC, which is the total volume of the lungs when filled with as much air as possible. Now, the normal value of these parameters is greater than or equal to 80% of the predicted value based on your age, sex, race, ethnicity, and height. And it's important to monitor the trend of these values over time. But pulmonary function tests can be in the normal range even when someone has interstitial lung disease. And that's why it's important to get a chest CT scan as well, at least at baseline. Now, a chest CT uses X-ray and computer technology to make detailed images of your internal organs. It's a non-invasive and safe test. The effective radiation dose from a high-resolution chest CT is similar to the annual exposure from background radiation in the US. A chest CT scanner is not enclosed like an MRI is, so claustrophobia is usually not a concern. And when screening for ILD, there is no intravenous contrast or dye that's used. Patients will be given specific breath holding instructions during the test. So for example, you'll be asked to take a deep breath in and hold it. You'll also be asked to breathe out and hold that. And chest CT is the gold standard test to diagnose interstitial lung disease. Tremendous progress has been made over the years in the treatment of systemic sclerosis associated ILD. And this is a timeline showing the publication of key clinical trials in scleroderma associated ILD, starting with the Scleroderma Lung Study 1 back in 2006. Fortunately, we have several medications in our armamentarium for the treatment of SSc-ILD, including our first two FDA-approved medications for this indication, nintedanib and tocilizumab. First-line treatment for SSc-ILD is typically mycophenolate mofetil, or MMF. But of course, this is something to discuss with your rheumatologist and or pulmonologist if you have SSc-ILD. So the last question you should ask your rheumatologist is, do I have interstitial lung disease? So I said I would show you this slide again. It includes all of the questions that I included throughout the talk. So take a photo, take a screenshot, and bring this with you to your rheumatology appointment and make sure you get your questions answered. And I will end with some take-home points. Know your scleroderma subtype, know your modified Rodnan skin score, and know your scleroderma-associated autoantibody. Get screened for pulmonary hypertension and interstitial lung disease, and monitor your blood pressure at home. Thank you, and I'm happy to take any questions.
Thank you so much, Dr. Bernstein, for sharing so much great information about scleroderma. I'm Omar Baker, and I'm a Scleroderma Research Foundation board member. I joined the board of directors earlier this year because scleroderma has affected me and my family personally. I lost my mother to scleroderma about 15 years ago, and now my mother-in-law was recently diagnosed with this disease. These experiences have deeply impacted me, which is why I'm glad to be here with all of you today as we learn more from Dr. Bernstein about scleroderma. We've had a number of people submit questions, so I'm going to start with those. The first question that came in for Dr. Bernstein is, how do you determine if scleroderma is limited or diffuse?
Yeah, so thank you for that question. That's a great question, and I am happy to explain this as many times as it takes because it can be very confusing. So as I showed at the beginning, for scleroderma, there's two main categories. There's localized and systemic. Localized is not the same as limited. So for today, we're going to forget about localized because we're talking about systemic sclerosis. So within systemic sclerosis, there's limited, diffuse, and then something called systemic sclerosis, CNA scleroderma. Okay. So the only difference between limited and diffuse cutaneous systemic sclerosis is where the skin is thickened. So people with the limited subtype have skin thickening that is limited to below the elbows. Can't really see in my camera, sorry, but below the elbows and below the knees. The face can be involved too in either limited or diffuse, so that doesn't help distinguish. But by definition, if someone has ever had skin thickening of the upper arm, of the thighs, of the chest, or the abdomen, they have diffuse cutaneous systemic sclerosis. So even if 20 years ago, someone had thickening of the upper arms and the thighs, but now their skin has improved and it's not really thick anymore, that person still has diffuse cutaneous systemic sclerosis. So the only distinction is where the skin is thickened. The autoantibody doesn't tell you the difference between the two. It is true that the centromere antibody is most commonly associated with the limited subtype, and the SEL70 antibody and the RNA polymerase III antibody are most commonly associated with the diffuse cutaneous subtype. But there are patients who have limited scleroderma and an SEL70 antibody. There are patients who have diffuse scleroderma and a centromere antibody. So the antibodies do not distinguish limited versus diffuse.
Thank you. That was extremely helpful. The next question that came in through the queue is, what are the current FDA-approved medications or treatments near approval that will be available to slow down the progression of this disease?
Yeah, so great question. So right now we have 2 FDA-approved medications for the treatment of scleroderma-associated interstitial lung disease. Those are nintedanib, which is an antifibrotic agent, and tocilizumab, which is an immunosuppressive agent that targets interleukin 6. That said, we have a lot more medications that we use off-label for both skin thickening in scleroderma and for interstitial lung disease in scleroderma. Something called mycophenolate mofetil is really what most rheumatologists and pulmonologists use as first-line treatment for scleroderma-associated ILD in this country, but it's not actually FDA approved for scleroderma ILD, but it is widely available and has been well studied in scleroderma. We also use medications like rituximab for scleroderma-associated interstitial lung disease, even though that is not FDA approved specifically for that indication. So we do rely on the use of other immunosuppressive agents that are on the market and approved for other autoimmune diseases as treatments for systemic sclerosis. And it's, I think, also very promising that there are many, many clinical trials right now for both scleroderma and scleroderma-associated ILD that are either ongoing or about to launch. So I think it's a very exciting time in the scleroderma community and the scleroderma research community.
Excellent. Well, I'm sure you get this next question all the time. Is there a cure?
Right. So unfortunately, there is not a cure, but there are treatments. And basically, we target treatment to the particular organ systems that are involved. So if someone has interstitial lung disease, we are typically treating with an immunosuppressive medication, again, such as mycophenolate mofetil. Also, if someone has skin thickening that requires treatment, again, we use an immunosuppressive medication such as mycophenolate mofetil. For pulmonary arterial hypertension, there are PAH targeted therapies that I showed in one of the slides that are used for that. We treat Raynaud's with a range of vasodilating medications, and we treat GERD with proton pump inhibitors and lifestyle and dietary modifications as well. So even though there's no cure overall, we do have medications to target the specific manifestations of systemic sclerosis.
Our next question is, what specific physicians should be part of a care team for a patient living with scleroderma?
Right. So I think first and foremost, a rheumatologist. Ideally, a rheumatologist who is comfortable managing patients with systemic sclerosis. So if you have access to a specialized scleroderma treatment center, that's certainly the way to go, if possible. I know that's not possible for all patients with systemic sclerosis, but the rheumatologist should really be the quarterback for your treatment team. And then, the involvement of other specialists or subspecialists really depends on what other organ systems are involved. So if a patient with systemic sclerosis has interstitial lung disease, a pulmonologist should be part of the treatment team. And ideally, a pulmonologist who is specialized in interstitial lung disease, because just like some rheumatologists have subspecialties within rheumatology, scleroderma, lupus, rheumatoid arthritis, pulmonologists also sometimes have subspecialties within pulmonary. And there are some ILD-focused pulmonologists out there at ILD, specialty care centers. If someone has pulmonary hypertension, then a pulmonary hypertension specialist should be part of the team. And depending where you are, that might be a pulmonologist or a cardiologist. And then if a patient has refractory GERD or reflux, or problems with gastrointestinal motility, whether that's esophageal dysmotility, gastroparesis, or either small bowel involvement or colonic involvement, I think it's important to have a gastroenterologist as part of your treatment team as well. For people who have musculoskeletal involvement with a lot of joint pain, potentially joint contractures, having a physical therapist or occupational therapist as part of your team is also really helpful.
Well, thank you so much. Really, it's physicians like you, Dr. Bernstein, that give us both solace and optimism for the future around this disease. And I've had the privilege of meeting you and listening to you today. It's really your focus on evidence-based medicine coupled with the compassionate care that's most impressive. So thank you for everything you've done in sharing this wealth of information with the community. We will pause here, and that's all the time we have for today. For those who are watching and tuned in, if you asked a question that we didn't answer yet, the SRF staff will follow up to you by email. Thank you so much for joining us, and I hope you enjoy the next session.
Thank you.